So continuing the TRP syndrome, so we defined it. Uh, Causes of hyponatremia. So basically, glycine-rich hypotonic irrigation saline is used for the irrigation of the urinary tract. To avoid clots, so it gets absorbed into body and causes severe hyponatremia. Glycine is used instead of saline because the conventional isotonic solutions limit diathermy use. Okay. So the definition is also dilution of hypotonic hypervolemia due to the use of glycine-rich isotonic irrigation solution, which will be absorbed and metabolized, leading to severe dilution hyponatremia. Glycine is used instead of saline because conventional isotonic solution limited diathermy use. For transurethral resection of prostate, the resectoscope is inserted transurethral. Electric current is passed through the diathermy loop at the end of the instrument. The surgeon moves this back and forth to create a cavity using diathermy to cauterize as they go. The resultant chips or washout of the bladder intermittently through the procedure. A visual image of the operative field is transmitted through the lenses running in the middle of the resectoscope. Around this lens, irrigating fluid is instilled and flows out, washing blood away from the operative field. Thus, you can see the field. The procedure is complete when an adequate channel has been created through the prostate. Okay, so this is the diagrammatic presentation, and here you can see that we have the cell. See the cell, and so this is the cell, and you have the hypotonic cell solution, isotonic solution, and the hypotonic solution. So if this cell is put in the hypotonic solution, this will swell because the outside isotonic solution or hypotonic solution will go into the cell, cytoplasm. So resultant, the cell will swell up. Isotonic solution cell, there will be no change. Like this is constant or balanced environment. And here, if the solution is hypertonic, so they will take up or squeeze out the water out of the cells. So now we have clinical pictures of TURP is restlessness, confusion, blurred vision, initial hypertension followed by hypotension, heart failure, and pulmonary edema. So these are the this will be the clinical picture of the TURP syndrome. So how will you treat this patient with hyponatremia and low BP? So hyponatremia here is dilution, therefore we will be treated by diuretics. Give him diuretics less X up to 40 or 80 milligram, and normal saline. Hypertonic saline will cause more sodium overload, so you can give him normal saline for the BP, and you can give diuretics to lose or get rid of the free water and fluid restriction. Causes of confusion, so hyponatremia, cerebral edema. So if there is hyponatremia, so if there is hyponatremia, it will cause cerebral edema because the free water will go into the neural cells, because this hypotonic, so they will go into the hypertonic intracellular levels of the brain cells or neurological cells. Hypoxia and high ammonia. Glycine is broken down to ammonia in the liver. Glycine toxicity. So causes of hypoxia. So pulmonary edema, water overload, reduced plasma osmolarity, and water overload reduced plasma osmolarity. As a result, there is a shift of fluid out of the plasma into the alveoli. So the fluid will move into the alveoli, or there is overload throughout the body, so the blood will go into the alveoli, so it will cause pulmonary edema. So this will cause ultimately hypoxia. What other systems could be affected? Heart can be affected. It can cause hyperdynamic heart failure. Where will you manage this patient and why? I will manage this patient in HDU because of significant physiological deterioration which will require monitoring and treatment. What other problems should anticipate in this patient? So CNS, CVS, respiratory and hepatic. So arrhythmias, cardiac arrhythmias can occur, and cardiac arrhythmias can occur because of acute changes in sodium concentration and extracellular osmolality. Seizures due to combination of hyponatremia and cerebral edema. Glycine toxicity causes encephalopathy and hepatotoxicity. Hypoxia due to pulmonary edema from overload. So these can occur. So this can cause cerebral edema and hyperdynamic failure and pulmonary edema and glycine toxicity. So these are the four anticipations. ABC protocol according to CRISP: stop the operation if ongoing and prevent further irrigation of by hypotonic fluid. Consider intubation according to consciousness level, or order ABGs and electrolytes, correct hypothermia using bear hugger, infusion of warm fluids, furosemide to correct fluid overload, refer to HDO, replacement of sodium, but not more than 10 millimole per day because of osmotic demyelination syndrome. So you have to correct sodium by 1 to 4.5 to 1 millimole per liter per hour. Okay. Will you give hypertonic saline? Acute severe symptomatic hyponatremia. So I will give if sodium level is less than 110 millimole per liter. So I will give 250 to 500 ml or 3% saline through central line, maximum 10 millimole per day. Maximum 10 millimole per day. So until symptom resolves or sodium is greater than 125. Yes. So which diuretics will you use? Osmotic diuretics mannitol to remove water and conserve sodium. So you have to get rid of free water. And can also use loop diuretics, furosemide as well. So action of furosemide. So site of action is thick ascending limb of loop of Henle. So this is the loop of Henle, and this is the thick ascending limb. Thick ascending limb. So here the osmotic, you can see the three. The three is your loop diuretic furosemide. So furosemide work on thick ascending limb. So site of action, thick ascending limb of loop of Henle. Mechanism inhibits sodium potassium chloride co-transporters pump, causing increased infusion of water with sodium chloride, magnesium and potassium ions. Other diuretics and their mechanism of action is also given. So osmotic diuretics mannitol mostly increases the osmotic pressure in the tubules and resulting in water secretion. They mostly act on the proximal convoluted tubules. And thiazide diuretics, distal convoluted tubule, inhibits sodium reabsorption. Potassium sparing diuretics, spironolactone, aldosterone, antagonize axon distal convoluted tubules, so they block the sodium potassium pumps. Amiloride binds to sodium channels at distal convoluted tubules. So let's see here. You can see first the acetazolamide, it acts on the proximal convoluted tubules and acts here. And then we have the osmotic diuretics mannitol, they also work on the proximal convoluted tubules. This is the proximal convoluted tubules. So mannitol and acetazolamide, they act here. And then we have the loop diuretics. So loop diuretics, furosemide, act here on the ascending thick loop, and they inhibit the sodium potassium chloride channels. And then we have the thiazides. Thiazides work on the distal convoluted tubule. So they, as we earlier discussed, that they inhibit the sodium reabsorption here in the distal convoluted tubules. And then we have the potassium sparing diuretic, they are aldosterone antagonist. So when there is no aldosterone, there will be no absorption of sodium. and excretion of potassium. So they inhibit the sodium potassium ATPase pump. Sodium potassium ATPase pump. Okay, so ascending limb of loop of Henle furosemide, so up to 25% filter sodium excreted, so up to 25% of sodium is excreted here. Distal tubule, so they will block this. Distal tubules and connecting segment, uh, thiazides work on them. So sodium chloride carrier between 3 to 5% blockage or promoting excretion, and cortical collecting tubules. Okay, so they are also showing you the percentage of water as well. So about 65 to 70% of the body water are absorbed in the proximal convoluted tubules. Rest is like 25% in the loop of Henle, and then distal convoluted tubule 3 to 5% and 1 to 2% collecting cortical tubules, where spironolactone, sodium potassium ATPase pump act on those. So sodium potassium ATPase, spironolactone. So we have these. So here you can see again the uh, carbonic anhydrase works on proximal convoluted tubules, and 65 to 70% of the sodium is reabsorbed in the proximal convoluted tubule. And then we have here the loop of Henle, the furosemides or the loop diuretics. So 25% of sodium is reabsorbed here, so it blocks this level, the reabsorption at this level. And then we have the distal convoluted tubule, where sodium chloride co-transporter is or carrier is blocked by the thiazides. And then we have these potassium spin diuretics, where they block sodium potassium ATPase. So yes, so this was all about the Turp syndrome.